Hey, everybody, and welcome back to another episode of Soul Focus Radio. This is your host, Martin Friedman, and I'm excited to be joined once again by Martina Tam. Hey, Martina.
Hey, Martin, how's it going?
It's going great, and I really enjoyed getting to know you a little bit more. I learned some things about you I didn't know, and I know that our listeners learned a lot about you. So I really wanted to jump in where we left off last time. I said, as we were talking about the cultural reconnective therapy and the different approaches to consumers and providers of healthcare, it made me think of an ongoing conversation I've been having. It's really intensified over the last couple of days and the last week or two, which is, when we look at all of our systems and institutions, they are currently, there's two things we know about them currently, right? Lots of things we know. One of them is we know that they're very racially inequitable. We know, especially in healthcare, we know the huge racial inequities. I mean, you talked about being pregnant, and we know that the disproportionality in birth outcomes, babies being born alive at healthy weight and making it to a year. We know there's a huge racial disparity, especially between Black women and white women. So we know that exists, of course, in every area. It's not just, maternal health care, but in every area, we know there's huge racial disparities and also disparities by class and by gender. The other thing that we know is that healthcare, along with many other systems, are very profitable right now. And the current model is a profitable model. It benefits right now healthcare institutions, to have people that are sick because that's the service provided, right? Is treatment. So what I'd really like to talk to you about is, how do we start to shift the model? Because it's one thing for us to say, oh, we care about equity in health, racial equity in healthcare, racially equitable healthcare, all of these different things that you hear all these institutions and systems talking about right now. But ultimately, the cost benefits analysis, how will that end up? How does it end up being beneficial or profitable to healthcare institutions and systems to really be about, people's wellness, holistic wellness, and not just about treatment and all the money they're making off of treatment?
Yeah, that's such a good question. And we talked a little bit about this when you were here the other day. And something I think about that, and you said this, is, right now we have a capitalist society and system, and it's going to be there for a while. So how do we work within that framework while creating something new and different? And I think right now a lot of where we could make some changes is, healthcare is a multi-million-dollar industry, billion-dollar industry. And I think we have to look at who is making the money. And so like you said, we get paid. So like my health clinic, every health clinic, you get paid based off of how high you code a visit. And I
Right.
can code a visit higher based on how sick someone is. The healthier someone is, the lower the code, the lower the reimbursement. So just like you said, I'm getting paid for people who are sick. And so that there's a total disincentive from a financial aspect for people to be healthy.
Right.
And I give this example, and you've heard me give this example before of, ancient China. And I talked a little bit in our first recording about how I did, my initial training was in acupuncture.
Mm-hmm.
And in ancient China, physicians were paid every day that you were healthy.
Right.
And the days that you got sick were the days that they didn't get paid because they weren't doing their job. And that's the exact opposite of us. I think about all the patients I would be getting paid for in that model are the patients I don't know because they're so well, they don't come to the doctor. Because you don't come to the doctor if you're well or to be well, really. And so how ironic is that? Is the people I don't meet are the people who are usually the healthiest. And so as we start thinking about that framework, something that's really affected the way that I've started thinking about my care is, I think I gave this example in a training we did, is what if I got reimbursed for every child I took care of for the number of kids who did not develop diabetes as adults, or for the number of children who, if thinking about the OB care and the pregnant moms I take care of, we know that stress in utero affects a kid's life and their health later
Mhm.
on.
Right.
Increased risk of heart disease, diabetes, even osteoporosis, depression. So what if my care for that pregnant mom is reimbursed based off of how well these kids do in their with healthy weights growing into their childhood and into their teenage years? And if that was our reimbursement model, it would absolutely transform the way that I was trained to be a physician. And there would still be reimbursement. It's still a capitalistic model because it's about payment. But then we'd
Mm.
be getting the people making the money wouldn't be the big pharmaceutical companies, but it would be, education sources, making money that insurance would be paying for moms to go to educational classes, for us to be paying for time off for moms to be able to actually take care of their bodies while they're pregnant, paying for healthy food. So who's getting rewarded would be somebody else.
Hmm. Hmm. That's really interesting because I was even as you were talking before you said that last part, I was thinking about, well, how does this get funded, right? Because we know how everything gets funded now. It's all through the insurance. It's all through the pharmaceutical companies. That's where the funding all comes from, right?
Mm-hmm.
So I think that's not to just be totally practical because I think practical is doesn't honor that integration of consciousness like we talk about because practical comes from what we consider to be practical comes from a very white cultural place usually, right?
Mm-hmm.
And it's just these are considerations I think because I think part of what we ended up talking about last time is we talked about creating, and instead of just always talking about how bad the disproportionalities are in healthcare and fighting against it, but what can we legitimately create? And so I think this model that you're putting forth is really powerful.
Yeah, and what I think is so profound for me as a physician, because when I first said this idea in a training, I had a well child check the next day, and I was just thinking to myself, well, gosh, I don't really know how to support this family so this kid can be healthy in all the ways I'm talking about. And so it would totally transform how we're training providers. Even, I mean, if you look at the data on how much nutrition education most medical students get, it's like
Right.
0 hours to maybe, I think at Tulane, they have the highest, which is maybe like, I don't know, I'm making up a number, but still not that significant of nutrition education. Like, I'm completely ignorant about nutrition from my
Hmm.
medical training.
Hmm.
And, how infrequent, like, I think about in my own visits as a pregnant person going to the OB, I've never been asked about my mental health.
Hmm.
And we know how much that affects moms and then affects baby and will affect that baby for the rest of their life potentially. So it's just
Hmm.
not on our radar. And I think when I talk with other friends in medicine about this, we have the models of like value-based care and reimbursement based, like with accountable care organizations, which is a step in the right direction. But
Right.
it's more about, well, can you keep these numbers low enough? Can you get enough people to be screened for breast cancer and colon cancer? How many people's diabetes is well controlled? But it's not actually this fundamental aspect of integration, like you're talking about, this idea of what do I want my health to look like?
Hmm.
And like, I want to have a life where I never have a chronic disease. And that's what my goal should be for all of my patients.
Right. That's fascinating what you're saying right now because I was thinking about when you were talking earlier, you're saying, that in China you get paid for how many healthy people, right? Not how many sick
Mhm.
people. And I was also thinking about how amazing would it be to build in incentives for doctors to take care of themselves for their own
Oh,
self
yeah.
care, right? Because and I know self care is an overused terminology, but to really like I grew up. I don't know if people still say this phrase anymore, but I grew up with the saying "physician, heal thyself." I don't know where that
Mhm.
comes from, but I used to hear that all the time. It was a metaphor too for anybody, right? Like psychiatrist, heal thyself, or you know what I mean. Like, but that the reason why we have that phrase is because you have so many doctors and other people in the healthcare profession that weren't taking care of themselves. I remember reading something years and years ago about the suicide rates especially among surgeons, the drug abuse and alcohol abuse rates, the mental health issues, that people that were delivering the medical care were experiencing themselves. So I almost like wonder if we could work that in too, as part of this new approach to healthcare.
Absolutely, because I think also if we're able to find real ways for people to be healthy, and like I said, I don't meet my healthy patients because
Right,
their health comes from all these non-medical things, their socioeconomic status, we
right,
think about what adverse childhood events they experienced, what neighborhood they live in. Those are all the things keeping my patients healthy. And so it's
right,
almost this impossible task as providers, to help people be healthy, but not having the tools because so much of health happens outside of what a physician is equipped to do and outside of the clinic. And so we're
right.
just constantly doing these band-aid fixes, which is, totally a recipe for burnout.
Yeah,
And
it
if we
really
could,
is.
yeah,
Oh,
and if we can
keep going.
incorporate people and, if we can reimburse nutritionists and teachers and social workers in a way that physicians are being reimbursed for because we recognize their effect on health, then I imagine those folks will burn out less and we'll have more people entering those jobs. Like you look at which specialties are really popular in medicine, and it's the ones with high reimbursement and the chill lifestyle. And that's completely dictated by what insurance reimburses. So, like
Right.
dermatologists make great money because they do a lot of procedures which are reimbursed at a higher rate. And that is decided by insurance companies.
Hmm. Interesting. So that's what really drives it then.
Yeah.
So it really is. I mean, it's a for-profit model is what really drives many healthcare decisions.
Oh, absolutely.
Yeah. And again, like I said earlier, the question is how do we make prevention and whole, because really what I heard you saying earlier is you're really talking about holistic medicine, right? You're really
Hmm.
talking about an approach where things are not disconnected, you're not siloed, right? Where everything is, mental health is taken into consideration in OBGYN, and nutrition is taken into consideration in general practice, and all the different things that you said, I think are really, it's really powerful, to think about a healthcare system that was more balanced and holistic, and where the decisions were not driven by what's the most profitable route about whether or not somebody gets to stay in the hospital. My sister recently had a knee construction surgery, and she didn't have necessarily complications, but her healing process was challenging for her, and where she lives was challenging for her to heal. And just to watch them go through the process of whether or not she could stay in the hospital, whether or not she could go to a rehab, and how that decision process was being made, it really was not about her best interest. I mean, she really had to have people advocating for her to be able to stay in the hospital longer and to be able to go to rehab. But I just think about how many people that wouldn't have happened for, you know,
Hmm.
and definitely like it was the best thing for her, but it wasn't going to happen unless a lot of strings were pulled and a lot of pressure was put on people to make that decision.
Right, exactly. And that it shouldn't be like that. It shouldn't be if you scream loud enough, you get the care you need.
Hey, well, I was going to refer back to what you said earlier, which is also socioeconomic status plays in that too, because like who also often plays into, like, it's not just your voice being loud, because your voice can be loud, but if you're coming from low socioeconomic status, it may not be listened to as
Oh,
much.
absolutely. And
Yeah,
the way we label people, like if we're caring for another physician in in the hospital and we know
right.
they're a doctor, the
Yep.
way that they get cared for versus another person, if you're a person of color, I mean, all
Mm,
those things, it's so apparent the language we use, non-compliant, left
mm,
against medical advice, and how that
true.
then frames the way we see that person.
Right, right. And then that I'm sure feeds into like just the implicit bias into how people are treated differently based on race, gender, class, socioeconomic class, all of that, right?
Absolutely. It reminds me of a story. So the other day I was working in the hospital with our residents and they were presenting a new patient who was admitted overnight. So none of us had met this person before. And they were talking, he was a young guy had really bad kidney disease, was in like renal failure, and he's like in his 40s.
Mm-hmm.
And part of the presentation was, he has a history of leaving against medical advice.
Mm.
And we were starting to incorporate something in our rounds where we go around and we talk about the patients before we go and see them, and the residents present their plan of after each presentation, the resident reflecting on what was their bias when they read
Right.
the chart or in their care for the person. And the resident was reflecting, well, hearing that he's left against medical advice several times makes me think he's going to be a difficult patient, even though I've never met him. And we had
Mm.
this discussion about reframing that, of saying, well, what did we do in our care that made it so somebody left against medical advice?
Mm.
And so
Hmm.
as we dug into that, then when we met the patient, we found out he's a single dad to a 5-year-old and a 7-year-old. He cannot be in the hospital for weeks on end because there's no one to take care of his kids.
Right.
And so much of the time in the hospital is often just waiting for something to happen because there's some red tape, or waiting, for him in his case, getting him on dialysis, getting these procedures done, theoretically could be done in like 2 days. And so I think
Right.
it was really helpful for us to reframe that, we're part of why someone might leave against medical advice, or why someone doesn't take their medicine as prescribed, and like owning our accountability, because it's a relationship, and no one ever just does what someone else tells them to do, or they shouldn't, at least.
Right. I agree. I agree 100%. And, I think your example, like, how much have you seen that racially implicit bias, that I guess it's not just race, but race, implicit bias based on race, implicit bias based on class, on gender, on sexuality, on ability. How have you seen that play out in other ways too, in terms of your training and your experiences in the medical field?
Oh yeah, I mean, it's so many ways, Martin. There's the subtle ways, and then there's the really obvious ways. And like one example that really struck me and maybe pushed me out of this ignorance I had was when I was a med student. I was working out in Wyoming on the Wind River Reservation. I remember this patient came into clinic, and she was just really sick. She'd lost a lot of weight. The doctor didn't know why. We couldn't figure it out. And she just, had gone from being someone who could go to work to now 3, 4 weeks later was in a wheelchair. We didn't know why.
Hmm.
And so the doctor recommended, I really think you need to go to the hospital, which was in town and off of the reservation, to figure out what's going on.
Hmm.
And the patient and her son were so adamant, and, amazingly were open enough to share with us that, no, we won't go. Like, so many times we've been to that hospital and we've been treated horribly. People don't trust us. They don't give us a basic care. Like, people just not, cleaning their mom when she was in the hospital, and
Mm.
helping with, basic human hygiene,
Mm.
because of the racism in the hospital. And it was such a profound example to me of, gosh, this woman is dying, and she will probably die at home because she doesn't trust the hospital for very legitimate reasons because of racism.
Yeah.
And it's how many times does that happen, even on a subconscious level, for patients that we don't go in because we don't trust the system, and then very fairly not trusting the system and leading to death.
Mm.
And then there's those subtle things, like just so many times, I would overhear nurses on labor and delivery saying things like, oh, well, I don't need to call for the epidural right now for this patient in labor. She's Latina, like she's built to have babies. Even a colleague of mine who's Asian American saying, I wanted an epidural, but I really felt pressured by the nurses to not, because they kept being like, oh, you're so stoic. You Asians
Mm.
are so so strong. So she felt this
Wow.
pressure to not have an epidural. And for all 3 of her kids, she's like, all I wanted was an epidural.
Mm. Wow.
Um, and I mean, I could just go on. There's so much.
Yeah.
And I
Yeah.
think there's like, if you look at the quality improvement, like trainings and framework, there's this saying in quality improvement that every system is perfectly designed for the outcomes that it gets.
Mm.
And if you apply that to healthcare and you look at all the statistics of the disparities in health due to racism, it's pretty horrifying if you accept that and apply that same mentality that our healthcare system is designed for people of color and for poor people to die at younger ages, to have worse quality of life. And if we accept that, and for me as a provider, if I accept that this is the system I'm working in, it's really horrifying and something that I think I really have to reckon with, and I'm still reckoning with, is how do I sit with that, knowing that I'm a part of this system, and then also feeling and truly believing I have the power, with my community to change it to something that is designed to have the best outcomes possible for all of our communities.
Mm. Yeah, that goes back to the earlier part of our conversation, right? That literally, I love how you said that, the design, right? We have to redesign it. I had a colleague in this work, one of the organizations I used to work for, who was like a 28-year veteran of a police force. And then later in his life, after he retired, he became an anti-racist trainer, right? And, one of the things I heard him say is absolutely it makes sense that people would hit the streets when somebody gets killed by police officers, right? When an unarmed black person gets killed by police officers, it makes sense, the anger and the outrage. And he said on that same day, how many hundreds of people, in that same city, how many hundreds of black people or other people of color died in the healthcare system because of racism, but nobody ever goes in the street for that.
Mm-hmm. Well, I mean, that's something I think about so much, Martin, and I'm glad you brought that up, is I think so much in healthcare, we have blamed the individual for their bad health.
Mm-hmm.
Like we blame, either we blame someone's genetics. We say, well, Black people, Native Americans, whoever are at higher risk for these diseases because of their genetics, which is totally, I don't believe in. I was about to swear, but I think is completely false.
Right.
And if you actually look at the data of our genetics, it is false. So
Mm.
that's one mentality, and that is so pervasive in the medical system, to believe that the genetics of different races is different, and that's why we have different disease prevalence.
Right.
And then number two is we blame people's lifestyle. Well, you have diabetes because XYZ. You have heart disease because you did this. And just like that patient who was leaving against medical advice, I mean, I think so much of the mentality of healthcare providers who cared for him was, well, you're having worsening renal failure at age 40 because you keep leaving the hospital.
Mm-hmm.
When really it's, wow, you were trying to take care of a 5 and a 7-year-old as a single father, and the healthcare system has not supported you in that.
Mm.
And I wondered if he was, from a higher socioeconomic status, he was Black too. So if he had been white, how
Mm-hmm.
different that dialogue would have been about him and how different his care would have been. And, his life is going to be shorter. He's going to be on dialysis in his 40s.
Mm.
And how much of that was preventable?
Mm.
I would say most of it.
Right. I mean, that's sad. It's
Mm-hmm.
really crazy, and it's crazy that how much we accept racism in that system. And I know there are people working on the issue, quote unquote, but we don't seem to have the same level of outrage. We seem to be more accepting of the number of people that are suffering and dying, people of color especially, and lower socioeconomic status, women who are suffering and dying in the healthcare system. I think that with this last bit of time that we have, we can kind of come full circle on our podcast and talk a little bit more about what does that redesign look like for you. And I know you talked a little bit on the last episode about some work that you did in Alaska that gave you hope. What gives you hope? How do you see this redesign happening? And, what gives you hope in terms of us being able to, literally, like you say, change the design? I love how you said it, because it's like people say, well, these systems are broken because they don't serve everybody equally based on race, gender, and class. But, as you said, no, they're actually not broken at all, right? They're
Mm-hmm.
functioning exactly how they were intended. So,
Mm-hmm.
what does that look like for you moving forward, and how are you hopeful?
Yeah, that's a great question. I love that. Let's end on a note of hope. I think, for me on a really small scale, personally as a physician, I'm seeing how much I need to re-educate myself, unlearn a lot of what I learned in medical school and residency, and then learn all the things I didn't. So read about how all the things I talked about, what actually is going to help prevent diabetes in a kid starting from childhood and helping families build those habits to prevent diabetes, 20, 30 years down the line. How can I start having better OB visits for my patients where I'm talking more about mental health and stress and preparing parents to become parents? And what does that mean? And educating, because I need to do that. I need to educate myself so I can help support my patients and share that information, and they can take whatever feels valuable to them. So I see
Right.
that on a really small scale. And then, like I mentioned, I work with residents. And so sort of paying it forward and trying to share what I'm learning with the residents and making that more of the standard education that they're getting, so they don't have to do the work as much to relearn or unlearn in their
Hmm.
residency. And then I think a really big gift of where I work is we are a smaller entity. And like we were talking about, we're an organization led by Indigenous people. And so I think there could be an opportunity to actually make some of these changes, because the folks who are leading us are also the folks getting the care from us. And
Hmm.
so they have an incentive to actually change what we can offer, because we're serving their aunties, uncles, grandparents, kids themselves. And so I think there's actually more of an incentive, more of that buy-in. And then also, being aware that I'm just thinking how doing this as a non-native person and just trying to learn from my native colleagues and the community,
Hmm.
because I have a lot of learning to do. So how do we collaborate and share ideas together?
Yeah. I mean, that's beautiful. And I think, it sounds like, what's happening is a shift, on a deep level. And that's what needs to happen. Just it's a shift in approach. And I think we have to start to message, going back. I know, sometimes people get tight, because it feels crass to them or whatever when we say, what's the benefit or what's the profit in ending racism. But and I get that. And we have to be able to start framing that as well. We have to be able to start framing what is the cost benefits analysis to shifting to a prevention model. How can people continue to make money? How can people benefit?
Mm-hmm.
I think it's okay to have that conversation, even as we start to shift and, shift accountabilities like you're talking about and shift, approach. I think there's a way we can talk about doing this that, still makes sense fiscally as well.
Absolutely.
That has to be the conversation. Well, thank you so much, Martina. I really hope we can continue this conversation in different ways, because you sparked a lot in me. I'm sure you'll spark a lot in our listeners. I just want to thank you so much for taking the time to record with me today.
Thank you, Martin. It was a pleasure. Really enjoyed talking with you, and I look forward to our next conversation.
Awesome. Me too. Me too. Well, we want to thank you. We want to thank everybody for listening. Thank all of you for being on this journey with us. Know that we love you. We care about you. We care about your health in all ways. We envision a healthy future and all that that means for all of us equitably. And we're so glad you're on that journey with us. Come check us out at soulfocusgroup.com. Listen to our podcast on all the platforms in which you can find it. Check out our YouTube channel. New content is going up on there. A lot of new and exciting things are happening, and we're glad that you're going to be a part of it. We ask you to stay safe, stay well, stay healthy, stay sane, and most of all, stay soul focused.